Our speakers today are Kay Jackson and Cindy Paul. Kay is the Manager of Software Certification and Compliance, Application Software at Iatrix Systems. Cindy, a registered nurse with over 20 years' experience in clinical nursing and public health education, is a consultant in our Professional Services Division at Audit Concerns. She's experienced in hospital compliance and quality improvement, meaningful use attestation, and audit readiness for hospitals. Cindy's primary role at Audit Concerns is meaningful use project management and consulting and clinical informatics. Today we also have Mike Eldon on the line. Mike is responsible for Audit Concerns patient engagement services, and we've asked him to join us to provide input specific to patient portals and engaging patients, and answer questions you might have around these topics. Now I will turn it over to Kay to get us started.
Thank you, Amanda, and hi, everyone. You know, when Cindy and I were talking about this educational session, the thing that came to mind for me was, what am I being asked over and over almost on a daily basis about concerns about meaningful use? So those are the items we're going to cover today. The recent updates, the stumbling blocks for Stage 2. We're going to talk about gap analysis and what that can really provide for you. I've helped 64 sites through their audits in the last couple of years, so I'm going to talk about some of my suggestions to have a meaningful and successful audit. And we'll talk about mock audits. We'll talk about IMO, which is a tool that a lot of hospitals are using for their mapping. And I'm just going to give you a couple of things about Meaningful Use 3 that really bother me. So first of all, what is the most recent change from CMS? You know, it's interesting that every day we turn around, there's something new. Stage 2 has been so different from my experience with Stage 1, and one of the things I think is different is CMS continually is changing the regulations. And also remember, another difference that's going to take place this year is starting in October, everybody will start and do, for hospitals, will do a full year. So no more of the 90 days, no more quarters. If you're attesting to Stage 1, Year 2 in 2014, and October the 1st, you're going to go into Stage 2. So you don't even have a break in there to prepare. So the NPRM, I think, is the response by CMS. It started back in December with a lot of people writing to CMS, HIMSS, CHIME, a lot of different organizations wrote to CMS and said, this is crazy. The timeline just doesn't match what's happening. So I guess in response to that, they first said in February, no, there's not going to be any delay. And I think it just continued to where in May they released the NPRM, and there's several things I want you to be aware of with the NPRM. One of the things is to evaluate what you're doing. I'm telling our customers, go forward with whatever you're planning to do, but have a plan B just in case. And I'm going to tell you a couple of reasons why I say that. So the updates from CMS, like I said, was issued in May, and it gives you the ability to use different combinations of your certified system. I'll give you an example. I'm working with a customer that has an ED system that just got certified in May. They will not get their certified for 2014 version until October. So that is an example of where they may be using 2014 and 2011 in combination to attest. Everybody has to have 2014 by October the 1st. The 60-day comment, and I can tell you I'm very disappointed that there isn't 5,000 comments out there. You know, I talk to everyone all the time about how disappointed they are that there hasn't been any relief, but when you go and look at the comments, there's only 636. Everybody should be making a comment, because this is how CMS is going to evaluate, is there really a need for this relief? So if you haven't done so, you've got just another couple of days. Go to the website, and we will be sending you these slides. The other thing to keep in mind is the rules for Stage 2 came out in August of 2012. And as you're aware, every vendor that wants to provide a certified system has to be certified by a testing body. The scripts for the vendors came out in January the 2nd of 2013, and the reporting period started October the 1st. So I've been in hospitals a long time. A 9-month period for vendors to get certified, for hospitals to get the new software loaded, to do all the workflow changes, it just was not a reasonable amount of time. So another reason I say this is important is because, like I said, having a backup plan just in case. This is the website where you can go and make the comments. I really, again, suggest you do it. Read some of the comments that are out there. The other thing I want to talk about is a new tool that CMS has provided. And I'm going to just switch over here and go to this tool. If you haven't seen it, I think everyone should do this exercise. So it's a CERT NPRM tool. We'll send you this link. But what you do is you go, what CERT edition are you using? So in my example of that site that's going to have to use 2011 and 2014, they would select that one. Then what stage are you in? Are you in stage 1? Then it tells you exactly what your options are. So you can do the 2013 stage 1 objectives, which means you have to do the 2013 CQMs as well. So again, go through this, and I'm just going to do the stage 2 just to give you the definitions for that too. So I think it's important that you evaluate this and have a plan B in place. If you don't currently have any way that you're tracking what you reported in 2013, you might want to look to see, are you still meeting those measures, and have that all ahead of time in case you do go to one of the Plan Bs. And, just a second, this is when we should hear something. Now, I've talked to several of my friends at CMS. I've listened to several recent webcasts, and they are going to make the comment, they say, by September the 1st. So you can see that is the last month of the last reporting period of 2014. So if you wait till September to get a Plan B, it may not be enough time. So I really, again, urge you to move forward with your Plan A, but make sure you have something in the background just in case. Use that tool to figure out what is the best thing for your hospital. CQMs, here's some questions I'm asked all the time. If everyone remembers, way back when the rules came out, they said nobody's going to be able to, if you're past stage 1, year 1, everyone has to do electronic submission of the CQMs. Well, now they've backed down, and I'll talk a little bit about why that happened, but now you will manually attest to your CQMs when you go to a test, when you do your core and menu. It's really strange how they've done the attestation pages for the CQMs. They are now by domain. So you may have a listing, you may have all your VTE together or all your stroke together, but when you go to a test, it's going to switch around to the domain that that particular measure is in. We have created a cheat sheet for attestation, so if any of you would like to have that, just write me and I'll send it to you. So what is the difference? When CMS first came out, it was QRDA Category 1. All the vendors had to be certified for that. QRDA Category 1 was aggregate data, so it's all the data for all the CQMs combined. They've changed it now, it's QRDA Category 3, and guess what? That is an individual file for every patient you have in your CQM batch. So if you've got 8,000 patients, you're going to have 8,000 uploads to CMS, well, to QualityNet, and it's going to have detailed information about each of those patients. So it may be time for you to look at your authorization. Make sure that you're covered because you will be sending that information to a third party. The 2015 rules for the CQM are supposed to come out next month. We don't know whether QRDA Category 3 is going to start in October. If it starts in October, are they going to do quarterly reporting or are they going to do yearly reporting? So if any of you are not a member of our iForum for Meaningful Use, you're welcome to join, and I will post it as soon as I find out.
Okay. This is Amanda. You are still on the website right now.
Oh, I'm so sorry.
Okay.
Okay. Now are we back?
Yes, you're back now.
Okay. I'm sorry, everybody. Thought I clicked it, and I guess I didn't. So the screen that you probably didn't see was the one right before it, where I just had what you should do. So all of these slides will be going to you. And also, start asking your questions now in chat if you have anything that you want to talk to us about or ask us a question. If we don't know, we'll find out for you and get back to you. The other thing about the CQMs is, guess what? Remember they said they didn't want any zeros? Well, now they've backed down and said zeros for the CQM are acceptable. I know a lot of our customers decided to track 18 or 19 of the CQMs, and they're going to pick the best 16. So I have one customer that's tracking all 29. Just remember that it's going to be a manual attestation when you go to a test. So stumbling blocks. This has probably been what I spend the majority of my time now working with customers and working with just anyone that calls me, in fact. is what did CMS really mean about the portal? You know, when I first read the specs, I thought, oh, they just want to make sure that every hospital, they have the information available within 36 hours. So we started going that route. Then CMS, I wrote to CMS, they go, oh, no, we want you to do this. And then they wrote me back and say, no, we were wrong, we want you to do this. So we've had 3 different opinions from CMS, and thank goodness they finally issued the FAQ. For the 6.1 is what we call it, the providing access to the portal. What CMS wants you to track is that you provided that patient everything they need to log on. So if you're asking and admitting and say, hey, do you want information for our portal, you can only count that when that patient has provided information. If they're not interested, that's a failure. My recommendation is that you don't even ask the patient. Just say, we're going to provide you access to the portal. All my years in working in a hospital, when you turn around and make it seem like it's something in it for them, it seems the patients are more receptive. Another thing I hear, well, we don't have, a lot of our patients don't have email addresses. We'll include in your information how to set up a Gmail account or a Yahoo account. I have lots of customers that have actually put a bank of PCs in the hospital. Or they say, go to the library. I have a lot that are even going around through the hospital, you know, nurses that have been out sick and can't work on the floor. People like that that can go and really explain to the patient or their families why it's important. So that's what you need to be tracking. It's almost what CMS said, the 36 hours is almost incidental. But they want any changes to that information to go to the portal after the fact for your patients. What I recommend is that you take a screenshot of your portal, redact the patient information to prove that you had the 3 things that are required. You have to have view, download, and transmit, all 3 turned on to be able to count. And I've got the FAQ here for you. At first it was kind of, I was hearing from CMS that you didn't have to have transmit turned on, but then they came back and said, no, we want the patient, even for stage 1 hospitals in 2014 that have to have a portal under the requirements and the changes, you have to have view, download, and transmit, all 3 turned on. I will tell you that CMS, and I can share this information in writing to everyone that's interested, we asked them about, is there any leeway or time that if a hospital is starting their reporting period July 1st and maybe they don't get transmit turned on to July 5th, they said that this measure and the transition of care measure both allow for that. It's a minimal amount of time before you can have the portal available. But what you have to do is if you don't get everything turned on till, say, July 5th, the denominator is going to start July 1st. The numerator is going to start on the day that that portal is a viable portal. And the other thing they left out is the method applies for this measure. So if you're doing observation service method, you'll follow that method. If you're doing all ED, you'll follow that method. So that is the patients you need to make sure you're giving access to the portal. If you're stage 2, of course, you're subject to the second part of that, which means that greater than 5% of your patients have to access the portal. And keep in mind, a lot of people forget, CMS doesn't believe in decimals. So for the providing access, it has to be 51%. For people accessing your portal, it has to be 6%. You know, Mike, let me ask you, I know you've been really involved with people and patient engagement. These are the stumbling blocks I've been hearing. What have you been hearing?
Well, the point is there are always going to be stumbling blocks. There's really no getting around it. But you can either stumble over them or you can be prepared for them and actually you can get over it. So if you have a portal plan in place, and this is what I'm going to talk about a little bit, is this portal plan, you should be able to anticipate or at least absorb any bumps that are in your way. So a portal plan should include some research about what the meaningful use criteria are, which is exactly what all of you on this call are doing right now. So good on you. You're all in a good spot there. But one thing you want to do is get a timeline together, implementation timeline, and formulate your plan around it. Because if you're not prepared, you're not going to meet your numbers, and that's pretty much it. So I try to tell my clients to bring the right people to the table. That's the first thing you have to do, is involve everyone who comes into contact with the patient. That could be anyone from pre-registration, pre-surgical screening, registration, nursing, hospitalists, case management, even volunteers. So everyone who interacts with the patients should be trained on the portal. They should undergo training on the portal. They should know exactly what it is, what the features are, and really know the basics of what's in it for the patient. So that involves, getting people in a room and showing them what the portal looks like. Another way to do that, actually, is to sort of have a beta period where you open the portal up to your employees and their families. That's just one idea of what you can do to familiarize them with the portal. But that's a huge stumbling block right there. People who just don't know enough about the portal to be able to speak to its benefits. If your employees don't know about it, they can't speak to what's in it for the patient. So one thing you want to do, if you really want to make that 6%, I know we talk about 5%, but it has to be over 5. Kay just mentioned it's important to aim beyond 5, not only for meaningful use, but just for the benefit of the patient. So what you do is you task someone, or you can task a team of people to approach as many inpatients as possible while they're still under your care. And this is crucial because once they're outside of the hospital, you don't know what they're going to do. But if they're under your care, you can sort of not force the issue, but you can tell them all about the portal while they're still there, and you can really tell who's using it and who's not, who's interested and who's not. So make sure you notify each registered patient. As Kay mentioned, it's so important to have sort of an opt-out policy. A lot of sites surprise me by not even asking each patient if they're aware of the portal. One thing you can do is just sign them up, and they can always opt out. And a lot of people neglect to market their portal sufficiently. You can do anything from brochures, posters, handouts, billboards, really whatever works for you. And it really depends on your budget, and you can actually do things pretty cheaply too if you do things in-house. But I even have a few sites offering a free cup of coffee, a coupon for a free cup of coffee. And Kay, I know we talked a little bit about that. You've heard of the same thing.
I have Starbucks gift cards if they log on before they leave the hospital.
Yeah, exactly. So, I mean, you can do that. You can raffle off an iPad or a car or something. I know that sounds ridiculous, but it's cheaper than missing out on meaningful use reimbursement. So another great idea is to even increase your patient callbacks. You can boost patient satisfaction, and at the same time, it's sort of a neat way to check up with patients to see if they've used the portal. So these are just a few ideas. But really, if you're looking at the bottom line, it's to be prepared, have that plan, train your people on the portal, market it, and you can always get creative if your numbers aren't where you'd like them to be. So really, that's pretty much it. Those are the elements that you have to think about. And as far as stumbling blocks, there are always going to be stumbling blocks. You just have to be prepared for them.
Thanks, Mike. And I tell people all the time, this is a measure we're not going to have any control over. That patient leaves the hospital, anything you can do. And it's not just getting your portal live. This measure is going to go on for years. So you need to have ongoing processes to look at what's happening and monitor your numbers.
That's right. And again, looking beyond that 5%, it's not going to be 5% for long. So always aim higher.
Yeah, I will point out there is an error in this FAQ. It says if the patient accesses it no later than the date of attestation, it's the end of your reporting period. They haven't corrected it yet, and I have that in writing because you could say, oh, gosh, I can wait till November 30th and get all my numbers in. But they said, no, they didn't mean attestation. They meant end of reporting period. So even their FAQ is wrong. I'm not surprised.
Laugh, but makes you shed a tear at the same time.
Yeah. So I want to quickly go through just the other stumbling block I'm hearing. That's Core 12. Core 12 is probably one of the misunderstood measures that I've worked with people on. The first part of that can be electronic or paper, but what I'm hearing is nurses don't want to print out a big paper of their transition of care document and give to them. The other thing is your HIE or HISP ready? I've been talking to customers that their HIE says we're not going to be ready till October. So just keep that in mind. When I was talking to CMS about the cost for direct mailboxes, what they said to me is, oh, they're not going to be free? I was like, see, you haven't even studied what you're telling people that they have to do. And I'll give you one more hint. When you send that, CMS does not want you to send unsolicited, just to keep sending them. They need to be sent to people that you know will receive And the word that the CMS is looking for is receive. They don't have to open it, but they have to receive it. And so what will happen is you'll get a message delivery notification sent back. And in all the wisdom, that message delivery notification does not contain any patient information for you to track back and close that circle. Another problem. A new FAQ came out this week on the summary of care, and I'm going to send that as a follow-up for everybody. It just clarified some things. So Cindy, I'm going to call on you now. What are you seeing when you're working with customers about their gaps in meaningful use?
I'm actually seeing a lot of issues where hospitals feel like they're ready. They believe that they're ready to start their attestation period. But when actually evaluating all of the different measures, we're finding that there are some significant gaps that could, in fact, keep them from being able to attest on their reporting period. So I want to just speak a little bit of how meaningful use, it truly can be an endeavor that takes a village. And many hospitals are finding that they don't have the resources that are needed for this meaningful use journey, whether it be with staff or financial means. And the reality is that though this journey requires a village, that village oftentimes is not there. So we've seen that rolling out meaningful use can oftentimes really stretch staff and budgets to the absolute limit, sometimes to the point where it's more than any nursing shortage that our country has ever experienced. So it really becomes important for hospitals to evaluate. In fact, some are looking at, is it even worth participating in meaningful use, or is it better to just take the penalties? So I'm not sure if you're seeing the same or hearing the same type of comments, Kay, but I know that there have been some hospitals that are just looking at, for right now, maybe not the long-term future, but for right now, it's better to just take some of those penalties rather than having to put that investment up front right now. So as I mentioned, this project management is difficult and can be very costly. And so hospitals are being faced with looking at having to pay higher salaries or overtime. Definitely staff retention is an issue with just staff getting burned out with everything that it takes for rolling out meaningful use. And physician engagement and training is also a really huge thing. So when you're looking at your IS departments are, already faced with the daily and weekly internal issues, but then now having to roll out new EHR implementations or patient portals, like you spoke to, the HISP connections. All of these things are just stretching IS departments, as well as, it's essential to have a team from your admissions and medical records, your clinical managers. And so these folks are not only committed to their primary roles, but now they're being asked to take on this team and be able to participate in rolling out meaningful use. So, and then most importantly, meaningful use really requires buy-in from your C-suite. If that buy-in is not there from your executives and from your governing board, then rolling out meaningful use can certainly be difficult. So with all that being said, I'd just like to say stop, take a deep breath, and there is a solution. So let's talk about how we deal with this issue. We'll deal with these issues. Okay, if you'd like to roll on to the next slide, let's talk about conducting a meaningful use gap analysis. Are you there, Kay?
Cindy, we may have lost her. Here she comes back, I think.
Yeah.
Okay.
I got dropped for some reason. Sorry about that.
Okay. No problem. All right. So looking at your meaningful use project management, we have found that customers are really benefiting from having a third party come in and conduct a gap analysis. And in looking at who can assist this, across the country there's 62 RECs, or Regional Extension Centers, nationwide that offer this type of service. There are also third-party vendors that can come in and assist with project management and conduct a gap analysis. And we really suggest that you get in touch with someone who you've worked with in the past, who you have a trust and working relationship with. And what this will offer is experts that can come in and really offer some guidance for your workflow, evaluating any gaps or any things that you really need to work on with your objectives. And these experts would have experience with working with several different of the EHR vendors, and also working with critical access hospitals all the way up to multi-system hospitals, or multi-facility hospital systems. So I guess the big question is why would you do this? Let me just give you an example about a recent situation that I've had working with a hospital. This is a 130-bed hospital. They're a Meditech Magic site, and they've recently experienced some staff retention issues where some of their key meaningful use coordinators left, and so they were left in a situation of somewhat not knowing what they didn't know. So they knew that there were some gaps in their meaningful use objectives, but not exactly sure of what some of the, digging down deep with the regulations were and exactly how to address them. So this was just 2 weeks before essentially starting the reporting period. And so I was called in to assist, and when we started looking at each of their objectives, in fact, it was very eye-opening to see that there were lots of gaps, and it was such an issue that if we didn't come to resolution and working through on these together, then they in fact would not have been able to attest. So having this gap analysis, I just want to emphasize that it's definitely helpful to have a third-party person come in, assist with that, and be able to really give you expert information and advice in how to deal with closing any of those gaps, working with your internal workflow, and to help address some of those internal stressors that your site may be experiencing. Now I'd like to shift focus back to Kay, and we can talk about some of the meaningful use audits that we're seeing.
Oh, yes. I have CIOs and CFOs call me almost like on a weekly basis recently. There's so many audits going on. And these are just some of my recommendations. At first they said they were going to do 1 in every 20. That was what was announced last year. But Congress came back and said, you need to do more. This is too much money for you not to be checking more. So just this year alone, we've had 21 customers that have received the audit letter. So really what my biggest recommendation is don't have some of the stories I'm going to share with you happen to you guys. Remember, it's an email. I've had sites that the email was sent and they missed their deadline because that person that did the attestation and had their email address were gone. Or a lot have ended up in their spam. So I really recommend, I call it Audit Friday. In just a second I'll tell you why I call it that. But these are 5 things that they're asking for in stage 1 in the audit letter. And you have to have this proof. They will, if you send it in through their portal and they go, okay, you were missing this thing, you still get a chance to give them additional information, but eventually they'll either say you've passed or you failed. And if you failed, you have to repay your money and then do the appeal. So just make sure, and my recommendations are that you be prepared for the audit. One of the things that people that I work with struggle with, and Cindy, you may have seen this too, is their risk assessment. We're going to send you as a follow-up the CMS guide, and it clearly states before you attest, you should follow the steps in there. The biggest thing that I've seen so far is not including your remediation plan. And I really recommend include your remediation plan up until today. Show them that you're continuing to work on any issues that were found during that security risk analysis. So what I call Friday, Audit Friday, is there is a way you can check. This is a screenshot from the attestation page. And if you're selected for an audit, this little tab right here will appear. So check it every Friday. Go back and see if you're being audited. Once you're audited, you can follow what's going on with the audit with this tab as well. If you don't have that tab, it's good news. And I say don't plan for when you're audited. It's going to be if. I've had customers that have been audited 2 times in a row. They passed the first time. They're being audited a second time. My other recommendation is you have at least 3 team members that are there when you're doing the attestation. I'll give you a couple of nightmares. I had one CIO call and said the person that did the attestation left and took everything with them. They had no proof. Another CIO called me and said, you know what, they did their testing for menu 10 and stage 1, but they didn't keep the proof that they did the testing. So the reason I say 3 people, that way more than one person is involved in the attestation and knows where your backup is. And I would say have 2 copies of your backup. Also, an attestation team. Have more than one person. I worked with one CIO that when he did his attestation, he accidentally put 100% in for a measure, and it wasn't 100%. So just have those second pair of eyes or third pair of eyes. So, Cindy, let me ask you, what are you seeing about audits? I know you've talked to customers. I've just had the experience of working with the 64 hospitals I've worked with. What have you seen, or when you came from your hospital experience, what was the concern at your hospital about audit?
Definitely the concern is all the documentation there? Is it easily accessible? Where, like you're talking, if someone leaves the facility and is no longer there, is there a traceable paper trail or document saved somewhere where that person can access and just pick up just to be able to provide all of that documentation? Like you said, when, not if, that audit notice hits the inbox. Also emphasizing definitely the importance of making sure that checking the website that you mentioned, just in case, like you said, if the person who filed the attestation, if they're no longer there, then that email is going to go somewhere. So it's better to get that in the beginning of when that notice is received, rather than you know, up until the date whenever the documents are, the deadline hits. So other things that I'm seeing is hospitals, do they really have the certainty if they're ready for that audit notice? Many hospitals believe that they are, but when it comes down to it, there may be certain pieces of the documentation that are missing. And as you mentioned, Kay, one of those big pieces is that working document of the security risk analysis remediation, and making sure that that's continually updated. Another thing I'm finding with audits is that there are oftentimes holes that get uncovered during the actual audit that hospital staff didn't really know was an issue. So that's something that I'm definitely seeing. And then also, like you mentioned, Kay, the importance of having a team of people. Just like the meaningful use project management, how that really takes a village, it certainly is the same for when an audit notice comes in. Number one, because of the time frame that is often very short for staff to be able to get all that documentation together, but it also sort of helps put the responsibility on the team and not just on one person. So looking at, you know, are there solutions or what can be done to help prepare for an audit? And so we recommend that many of our customers, what we've seen, have conducted a mock audit. And there are some benefits to this, having a third party come in and conduct the mock audit. And first this would be is that a team of experts will come in and they've had experience with working with other hospitals They oftentimes have direct connection with CMS and know exactly what Figliosi is going to be requesting whenever that actual notice comes in. So a mock audit expert is going to review the documentation and make sure that everything is there in place just as an actual CMS auditor would do. So you have that certainty that whenever your official notice comes, then you're in fact going to be ready. The expert will definitely make sure that all the documentation is there, the proof, and again, the recommendation is to have all of that in 2 different places. Another benefit to having an expert come in is with a mock audit is being able to offer certain tips or advice for best practices for handling an audit, as well as how to sort of maintain your staff efficiencies. The main thing to really keep in mind is just don't panic. We've seen that our customers who have done a mock audit say that it's really the best thing that they've ever done and that there's really a sense of relief, so that when that official notice comes, they're ready. They don't have to be, panicked or stressed about it. And definitely the most important aspect of an audit is to not go at it alone. Know that having a team to work together and then also having an expert come in and conduct the mock audit is certainly important. So going beyond mock audits, talking about patient experience. This is really the key focus for looking at stage 3 objectives. And what we really want to start thinking about, as Mike mentioned before, it's best to always stay a step ahead and anticipate what CMS is going to require in the future. So for stage 3, it's all about patient engagement, patient experience. And so you want to start looking at how are your patients using your portal. How are they accessing that? Is there a certain population of your patients that are accessing your portal? And what you can do to be able to market to different populations to maybe increase that patient engagement, like with your older populations, or you can also focus in on specific diagnoses that people are discharged with. Another issue that's really big is CMS evaluating patient experience with their physician or their provider and looking at, is that communication piece there and is it adequate? Are patients satisfied with the communication that is offered during their hospital stay as well as at discharge? Evaluating the discharge instructions and is it understandable? And then another objective really is patients receiving callbacks after discharge and being asked or followed up, was their discharge information understandable? Were they able to follow through with the instructions as far as getting their prescription or being able to follow up with their provider as recommended? So really for patients to really understand that piece of the discharge instruction, in addition to real comprehensive education resources about their diagnosis and how to go home and deal with that to prevent a readmission. And all of this really ties into quality of care and all of the quality initiatives that CMS is looking at. And lastly, for hospitals and eligible providers to really evaluate, is there room for improvement with the patient portal or their EHR, the different HIT applications that we're using? Are there areas that there could be workflow improvement or areas that we could encourage our patient experience and for our patients to express that they've had a great experience? And that's ultimately what we're looking for. So as you know, Mike is the expert on this, and he's still on the line, so he's going to be able to answer any questions as we anticipate and look to stage 3. So now I'd like to talk about IMO, Intelligent Medical Objects. IMO is a company that has partnered with Meditech and all EHR vendors to standardize medical terminology. And this is taking ICD-9, ICD-10 codes, SNOMED codes, LOINC codes, and standardizing all of that to an IMO-specific term. And the benefit to this is that it really populates within your EHR system where you're able to populate accurate problem lists. It's essential for CQM reporting, as Kay was mentioning, looking at 2015, and if the QRDA category is going to change. If it changes to the Category 3, then this IMO is ever more important. The IMO integration will also help to populate the data fields on your CCD. It's necessary for public health reporting, your patient portal, and oftentimes most important, your accurate abstracting and billing so that your hospitals are able to send out proper billing, and oftentimes that equates to significant savings. So again, this is a huge implementation, a really big project for hospitals to be faced with. So the question is there help for IMO? So just like we've talked about mock audits and gap analysis, I'd like to just go over a few things about the importance of bringing in an expert to help out with your IMO implementation. So on the next slide, we'll see that working with IMO can take up to 6 months. And this is information that has come from IMO and some of the EHR vendors. And they say this because truly the implementation from start to finish can take several months, and it varies depending on your staff resources. Definitely if you have internal resources that are working on it, again, it only stretches those limits that are already there. And the other issue with IMO that we're finding is whenever you send in your dictionaries and they map your codes, oftentimes what you receive back, there's only a 40 or 50% return rate of the terms that IMO was actually able to reconcile. So that leaves lots, thousands and thousands of terms that have to be mapped manually, and this is where the real extensive time frame can come in. So our customers that have had a third-party vendor come in have said that having someone assist with this project can reduce that time from 6 months to more like 2 to 3 months. And there's definitely a benefit in this because an expert who works with the IMO implementation is familiar with all of the implementation steps and the process. And oftentimes this can be the most difficult thing as far as just figuring out what IMO is and what steps are necessary and all of the different things that are required initially just for the implementation. So some of the other additional benefits that our customers are saying is that because there's an IMO expert to come in and help manage the project and do the reconciliation, there's always a first-time accuracy in reconciling those terms, and they're finding that there's an immediate return of investment by just reducing those internal resources that are required for the IMO implementation. And another benefit is, like I said, the experts from a third party can come in and they've worked with several hospitals with various EMRs and different stages of meaningful use. And so even though your dictionaries may be the same, every hospital site has different terminology. And so being able to decipher how it applies to the IMO code is certainly important. So these are all things that we felt like were important to discuss as far as stumbling blocks. So at this point, it's good for us to start looking to the future again with Stage 3, and Kay is going to talk about some of the issues for future reporting.
Did we lose you, Kay?
Can you hear me, Amanda?
Yes, I can hear you now.
Okay. I don't know. There's something going on with the phone lines for sure. I apologize, everybody. I wanted to close with what is happening or going to happen for Stage 3. And, of course, we don't know what the final is going to be. The final is going to be released next August, so a year and a month away, if that's when they come out with it. And the other huge thing that I think everyone needs to be aware of is CMS has also changed the certification. It is not mandatory for vendors, but each year they can go be recertified because there were so many errors with the Stage 2 and the 2014 regulations. CMS has said, you know what, we need to do additional certification. So your vendor may or not recertify. It's not required. I think it's important for the CQMs because those change yearly, and to get the most accurate reporting for your CQMs I think is vital. The two things that I think stuck out to me are, the number one, the hospitals are going to be receiving electronically information from their patients. So they may be sending you things back through their portal. You know, how are you going to handle that? How are you going to educate patients on how they can do that? We don't know what the final is going to be yet, but that's one that's going to stay. The one that really worries me is hospitals sending electronic notifications. This is, I don't know if this is going to pass or not, but what happens is if a patient triggers one of these events, they arrive to the ED, they're admitted to the hospital, they're discharged from the ED or hospital, or death, you have to notify that primary care provider, referring provider, care coordinator within 4 hours of the event. So this is going to be huge for all of us, and how is that going to work, and what's going to be the benefit? So that was something I want you to really keep in mind as you move forward. Even though the Stage 3 isn't publicized final yet, you need to be looking at what's involved in planning now. We've seen with Stage 2, it takes more than a year and a half to really move forward and get things that you need. And there was one thing I forgot to say, Cindy, was that when you get that audit notification, you only have 3 weeks to respond. So that's why I say look every Friday. If you don't, I've had 2 sites that have called and asked for an extension, and the auditor gave them 5 days, but that's probably not the norm. You wouldn't want to always ask for an extension on the audit. So, Amanda, I think that brings us to the close, brings us to our question and answers.
All right. We have a lot of questions here for you.
Oh, great.
Okay, the first one is, Kay stated that if the patient is not interested, you fail the measure. What if you educate them and give them all the information needed to self-enroll and say to them, this is what you need to do if you change your mind? Would you then be okay to say availability was met?
Yes. What CMS has said is they want you to provide that patient with everything that they need to create their own account. I see some people put not interested in a query to remind, just to indicate. I think that's not a good answer. I don't think, again, I think that what I've seen has been working better is to say, here's the information about our portal. Give them everything they need right then to enroll. Giving them a brochure about the portal without how they can access it doesn't count. So if my recommendation is, don't even ask them, say, here's the information. I have had hospitals that patients have come back after discharge and say, I turned it down and now I want it. The other thing to keep in mind about providing access, if you have some type of query that you provided access to that patient, keep in mind that there's another reporting year you're going to have to track. If you don't have some type of mechanism, because that patient may have been given access in 2014, comes back in 2015, they're going to be in the denominator. You want to make sure you can count them in the numerator. They've already been given access to the portal. Okay, Amanda?
Okay, then the next question is, in regards to the patient portal, I thought that to count for meaningful use Stage 2, the patient had to log in post-discharge. Kay stated,
no.
Have them log in before.
Nope, and I've got the FAQ to prove that. CMS came out in February at HIMSS and said, no, we encourage you to help your patients log on. And in the follow-up information I'll send that information. I think it was in one of the FAQs that I had on my screen, but I'll point out where it says they can occur while they're hospitalized. which is a good thing because that gives you the ability to work with that patient, get them to log on. Like I said, I've heard hospitals giving $5 gift cards to Starbucks if they log on with the hospital staff right then, and that does count towards your greater than 6%.
Okay, the next question is, I have heard that if a patient declines access to the portal, we can include them in the patients who had everything they needed to access the portal. It sounds like you just indicated that this is not true. Can you clarify?
Yes. What CMS wants you to do, again, is to provide that patient access with everything they need. If you don't ask them if they're interested, then you would never have that situation. Just provide them what they need to log on to the portal. It's their decision then what they're going to do with that information. But I stress, this is probably the third time I've said this, don't even ask the patient. Just say, we've got a portal now. It's going to be a huge benefit for you. We want you to enroll, and here's how you can sign in. I've worked with 12 different portals in the last year, and there's all different ways that the portal vendor provides you with that information that they need to create their account. So just do your workflow based on that vendor, how they give you the information, and encourage the patient to accept the information. If they accept it and don't log on, that's still going to count for your greater than 50%. It won't count for your greater than 6%.
Okay, the next question is, on the transition of care requirement, is there a time frame from the time of patient discharge that this summary must be received?
You know, I get asked that question all the time because it's silent. When I've talked to CMS, what they said is, Kay, you need to think, this is exactly their words, Kay, you need to think of what the reason we're doing transition of care is. The reason is we want that transferring provider to have all the information about that patient. So what they said to me is that transition of care should go out when that patient is being discharged. Although, again, there's nothing in the regulation. They just said you need to think about the whole benefit. Getting that transition of care 2 days later isn't going to help that transferring provider. And I'll send you I'm going to send the new things that came out about transition of care this week. It really talks about, a lot of sites say, well, we give our doctors access to our patient information so they can just look on there and get the transition of care information. In that FAQ I'm going to send you, it states that's not going to count. Okay, Amanda, another one?
Yep, the next question is, what specifically are the requirements for meeting Core 11 medication reconciliation?
You know, I just had a meeting this morning with all my nurses. We were discussing that. Why don't I add that to my information I'm going to send everybody, because I had one of my nurses write up everything that we've learned from CMS plus what we've learned from reading the final regulation. So I'll just include that in what I'm going to send out, Amanda, the whole under our understanding of MedRec.
Okay.
Because I know some hospitals say, we have patients come in and they don't have any prescriptions. You know, we've done the MedRec because we've asked them and they don't have any. I have other hospitals say, well, we don't do the MedRec till discharge. Again, there's nothing in the regulation that says when you're supposed to do it, but the benefit is what is the benefit to the patient. So I will send that information with our follow-up.
Okay, the next question is, where was the website that you recommended looking at the audit tab?
When you go to a test, you know, you can log on. Like you're going to go to a test. You log on with that password and the user that you have signed up. I recommend lots of hospitals have more than one person. You can go in there, and normally, here, let me go back to that slide and just show you. Oh, I don't know what's going on with this today, but let me just quickly show you that screenshot is where you go to attest. So it's right there on the page where you attest. And the benefit is you can follow, it gives you all of your recap, your registration information, your attestation information, your payment information. That's a great one to watch for when you're going to get your money. This tab will only appear when you're being audited. So it's the page where you do your attestation and track your payments.
Okay, the next question is, our private practice physicians are not really engaged in meeting the meaningful use requirements since there's nothing in this for them. They feel since this is for the hospital, we should do all the documentation on their behalf. How do you recommend addressing this?
Well, I'll get Cindy to answer that question too. I hear that all the time from hospitals that own physicians. In fact, I had a hospital group call me just Monday and said, we've got 150 physicians we think can attest, but they don't want to. and give us some pointers of why. You know, doctors can only do Medicare or Medicaid. They can't do both. Hospitals can do both, so they get a double dip in way with the incentive money. What I have found is the physicians that are owned by the hospital are guided better with meaningful use, and the requirement from upper management is you're going to do this. So I've got some other information. I'll put that as a follow-up to some recommendations of how to engage your physicians.
And I found also that, you know, though there might not be buy-in because they feel like that there's no benefit to them, there truly is. I mean, it will still equate to thousands, possibly hundreds of thousands of dollars for those individual physicians whenever they attest. So, you know, that can be a matter of them getting new equipment for their office, or you know, being able to have the capability for more staff. I mean, it truly does equate to significant money that can improve their own workflows within their practice.
And if they think they're going to get the incentive money is going to pay for all of their struggles and new systems that they're going to get, that probably won't be the case. One of my doctors said, you know what, I have a very small population of Medicare patients, no Medicaid patients, and I'm just not going to do meaningful use because I'm just going to get a small penalty on my payments, and it's just not worth the hassle. Okay, Amanda?
Okay, the next question is, we use the OBS method in calculating all our measures. Do you anticipate any hurdles regarding using this method? I had heard from others that this method could not be used for the patient portal objective. However, in my conversation with CMS, they indicated the OBS method or ER method were applicable to all measures.
That is absolutely true, and I have it in writing from CMS. That is silent. If you look at the Stage 2 spec sheets, almost all of them have, you know, the two methods that you can do. It's left out of Core 12 and Core 6. So I talked to CMS. In fact, this is another one they gave us the wrong answer to start with. They do apply to the portal, so if you're doing observation service method, you need to have your observation patients, your inpatients included. If you're doing the all ED, it's all your ED patients and all of your inpatients. The only measure that I have found that the method does not apply is advanced directive. Advanced directive says patients 65 and older and inpatients. That's all they want you to track. So that's the only one, and again, I can send all of this proof from CMS as well.
Okay, the next question is, for Core 12 and 6, are expired patients excluded from the measure?
You know, that is a debate I've had with a lot of people. There's nothing in the regulations that I can find. When I've talked to CMS about it, they said it has to be whatever the hospital decides that they want to do. Just like on the transition of care, Core 12, you can limit your discharge dispositions. You don't have to do all your discharge dispositions to be included. So to me, a deceased patient, I feel like you could exclude them. You just need to create a policy and procedure why you're going to do it. It's kind of like in the portal. If there's things that you don't want to have available in your portal, CMS has said that's fine. It might be of jeopardy to the health. Just write up your policy and procedure why you followed that method, and that's what I would recommend. If you're audited and they ask, you've got that documentation that was done before you attested. It's kind of hard for a dead patient to log on to a portal. And what is the value of sending a transition of care to a deceased patient?
Okay, the next question. Oh, I'm sorry. Go ahead. Kay.
No, go ahead. Go ahead.
The next question is, are you referring to the 5% number when you say giving information without providing access does not count?
The 5% number is patients that actually take the information you've given them and create their account and log on. They have to view, download, or transmit to count in that greater than 5%. The greater than 50% is, did you give them access? So that patient comes into your hospital, you give them the information of, maybe it's the medical record number. They can go in and create their own account. Maybe it's a special code that's generated by the portal. Instructions on how to do it, who to contact if they have any questions, how they can create their own email address, all the documentation that you're handing to that patient, either in their admit packet or their discharge packet, to talk to them about how they can create their own account. That's what CMS wants you to track for the greater than 50%.